Well, thank you so much for this kind invitation. I'm glad to say that since I share my information with Erin, I have been promoted. Now I'm the head of the adult pain services at our university. I have to present some disclosures. Number one, I'm here because I'm a passionate about cancer pain. I think that it is um, it is poorly understood, poorly treated, and it deserves more attention. And I'm not saying this just because you are here in front of me. Is a true passion. Number two is that I am passionate about cancer pain because there are certain things that I do with my hands that I believe that they can be very helpful. And the problem with physicians when we do things with our hands is that we start having weird ideas in our minds, like this type of God complex. And I'm not like that, but I certainly see patients that they feel that their quality of life is better. I'm here also, and I need to disclose because I need your help. And I'm gonna do, throughout the presentation, I hope that you will understand why. And my last disclosure is I'm here talking to you, patients, caregivers, and people interested in cancer pain, because not only am I a physician, but also cancer has struck my family. My wife, she's a cancer patient. She has sometimes pain, and as such, I need to help her as a physician, but also as a caregiver. So I'm involved in this field from two different hats. Let me start by saying something controversial. Pain is good. Yes, it's good. And the reason why it's good is because pain allows us to identify cancer. As you can see in this graph, the most frequent reason why someone complains and ends up being diagnosed with cancer is pain. Therefore, if it wasn't for pain, we wouldn't diagnose many cancers. Therefore, pain is good. As you can see, there are other symptoms that they are also prevalent in patients presenting with pain as an initial diagnosis. And the second is a lump. So either because it hurts or because you touch something that you feel that is not normal, that takes you to the hospital, takes you to your doctor, and that initiates the path of cancer. So pain is good because it protects us. So I want to talk to you about pain from a very basic point of view. And I want to talk to you about the nervous system, because the nervous system is the system that allows us to communicate between the environment and ourselves, and back to the environment by doing some actions. So the way that I see the nervous system is like a phone system. Someone calls. There is a switchboard that refers the call to the appropriate receiver, and then there is a receiver. So this is what I call it's mostly the peripheral nervous system, but also is part of the spinal cord, which is central nervous system. But that's a difference that you don't really need to know. So there are two actions. One is making a phone call, and that phone call is a stimulus, something that hurts. This message is sent to the spinal cord, and from the spinal cord is sent to the brain. And at the level of the brain, the phone call is received by different structures, and these are the structures that they put a voice to that call. So whether the message is ding dong, someone is knocking on the door, or whether the message is my cat is waving his tail under my chin and that's very pleasant, or whether a message is my pancreas is hurting. So what is really important in terms of understanding pain is the brain. The message that goes to the brain is pure electricity, but once it gets to the brain, then we understand what hurts. There is a joke that I always tell my students. There is a neurologist goes to the orthopedic physician with a tennis elbow. And then the orthopedic physician says, so where does it hurt? And the neurologist says, well, in my brain, of course. It's very bad. It's very bad. Father, that joke. Now, in the
Dr.
17,
Perez, I'm so
yes.
sorry to interrupt you. Some people are having a bit of trouble hearing. Are you able
Oh,
to move your mic a little bit closer? Some
yes,
people aren't, some
absolutely.
people are. Thank you.
Okay.
Oh,
I'll put it just in front of my mouth. I
that's
hope that
much
it.
louder. Yep, that's
I'm so
perfect.
sorry.
No, no, you're good. You're good. Thank you so much.
Right. In the 17th century, there was a French philosopher, René Descartes, who drove this this draw draw this scheme of how we feel pain. He said that there is a cord from the periphery that pulls a bell inside the brain, and he was not far from being wrong. Actually, this is the system that connects the periphery or the insides of our body to the brain is quite simple. It's a couple of neurons, a couple of connections, and that's it. So something hurts in your in your finger because you hit a nail. That sensation, which is pure electricity, goes to the spinal cord, which is the part of the switchboard that I mentioned, and it goes up to your brain. And depending on where in the brain it goes to, your body is gonna experience pain in your finger, in your fingertip, or in your palm, or in your elbow, or inside your body. So but you have to understand that there are certain areas of the brain that they correspond to larger areas of the body. So there are parts of the body that they need a very large brain representation, because it is very important that areas of the body they are very well represented in our brain. So you can see here is something that a Canadian neurosurgeon, Mr. Penfield, the, suggested is called the homunculus. And the homunculus says that there are the representation of the brain of our different parts of our body differs. There are, as you can see, the face is very well represented, and the hand, because the face and the hand they are probably the areas of our body that they are more connected to the rest of the world. They need to have a 5G connection, let's put it this way. And but it's true also that the pancreas and the viscera they have a connection to the brain. So when the stomach hurts, when the liver, when the pancreas hurts, there is a connection to the spinal cord, and the spinal cord sends a message to the brain, and there is one part of the brain that is activated. Unfortunately, or maybe not, that area of the brain is very poorly represented. Or let's rephrase. The pancreas and the abdomen and the abdominal organs are very poor represented inside the brain. It is much easier to understand the pain coming from your hand than the pain coming from the pancreas. And why is so? It's because when we were built, it was thought that it's more important to feel sensation from the outside than from the inside. That's why the brain representation of our outside, our skin, our tendons, our muscles, our bones, is much larger on the brain than our insides, my prostate, my liver, my pancreas, my ureters. So the body has created an alternative way to express, so to send the message to the brain. It's a mechanism that is quite unique. When something hurts inside, the message goes to an area of the brain that also corresponds to areas of the outside world, of the outside body. Or when I say outside body, I mean not inside, not our insides. The classical example is you're running and now suddenly you start having a pain, a chest pain, but mostly a shoulder pain that it's like a squeezing pain. And the shoulder hurts and you don't know what's going on. And you go to the doctor, and the doctor decides if you need to see a cardiologist or you need to see an orthopedic physician. But at least the pain took you to the ER. So you see that pain is good because it calls for an attention. But the heart is not represented well enough in our brain, so the heart has to use other systems in order to be heard. Well, the same happens with the pancreas. When the pancreas hurts, we don't know that it's the pancreas that is hurting, because sometimes what it hurts is the front of our chest, typically underneath the epigastrium, around the sternum a bit lower. Sometimes it's like a belt. Often it's pain in the back. And these are pains that we all have had before. we had a rough night and maybe we drank alcohol and the next day our tummy hurts, or maybe we eat something that we shouldn't have eaten, or lately we're a bit stressed and we have a bit of gastritis, or maybe we have been shoveling the snow, the ones above the border, and my back is a bit sore, and all that hurts. And these are areas of our body that often they hurt because there are millions of reasons for that. Who thinks that a back pain is going to be a pancreas? So if we go back to the reasons why um, cancer is identified, again, as I said, pain is the main reason. The problem is that when pancreas has a cancer and it hurts, typically you're going to have a pain that does never raise any type of attention, like back pain or abdomen pain, because we all have this type of pains. To make things even more complex, some people they get diagnosed luckily at earlier stages because they have an X-ray. For other reasons, there's plenty of people having a cough, they get an X-ray, and then suddenly they see sadly a lung cancer. Some other people they get blood tests and routinely they are checked for some tumor markers. But you know well that X-rays that doesn't show a pancreas cancer at the earlier stages, and the tumor markers for cancer, for pancreas cancer, they are not very well developed. All to say is that unfortunately, the most common type of cancer diagnosed at the beginning is the distant cancer, the one with metastasis, which we know that it's a bit, sorry, let's not, that it's harder to treat. Therefore, we are lacking, and this is where scientists they need to work harder. We are lacking at tools to diagnose early pancreatic cancer. And the only thing that you guys are experiencing when you are having an early pancreatic cancer is pain, and this is sometimes not enough. Let's continue with pain. So 50% of patients they have pain at diagnosis, and I would say hurrah, I wish it was more than that, because that way we will be able to identify cancer pain earlier. But once you know that you have a cancer, you don't need to feel pain, because that pain is not helping you identify the problem, because you know the problem already. So, and this is where the tragedy starts. I am not concerned about the first column, the first 50. Luckily, they have pain. But the 59% of people having pain during treatment and the 64% of people having pain at advanced stages, they are having a pain that only destroys the body and the mind. And the reason is because pain is supposed to be a warning sign. What is your pain warning you if you already know that you have a cancer? Well, you could argue that sometimes pain might warn you about a development related to your cancer, like a new metastasis or like a complication of the treatment. Well, I accept that. But in the most cases, pain is just a reminder that you are not well. It's just a reminder that the cancer is there and needs to be treated. So, in my mind, these pains, they are not helpful. Therefore, they need to be treated. And they need to be treated because pain affects the body and the mind and the soul and the environment. So when you have pain physically, your functional capability is decreased. And I'm sorry if I'm preaching to the choir. Your strength is diminished. And if you cannot be strong physically and mentally, you cannot be healthy for the poisons that you need to take to treat cancer. I'm not going to go over every single aspect of this because, as I said, I'm preaching to the choir. But I hope that you understand that we physicians, most of us, where we acknowledge the fact that pain affects us physically, psychologically, it affects us socially, and also affects us spiritually. And all these aspects of pain, they need to be treated. However, for a second, let's say that I put my shoes on, my oncology shoes, which I don't have because I'm an anesthetist, I'm a pain physician. But let's say that for a second, I wear my coat of oncology. So what if my patients, they have pain? I mean, are they going to be, I know that they are suffering, but so what? What I care is how many of them I can help them survive. How can I prove that my oncology treatments, surgery, radiotherapy, mostly surgery and chemotherapy, radiotherapy sometimes, how can I prove that I am improving survival and I'm prolonging survival? This is what matters for oncology. And this is where we need to help our oncologists. Because, Lord behold, there is research suggesting that the lower the pain, the longer your patients survive. So this is something that I fight continuously with our oncologists at our institution to prove them that a proper pain management is linked to prolonged survive. And I tell you, oncologists, they care about survival. They might care about the patient and the patient well-being. Most of them, I would say 99% of them, or maybe not, but it's very important that they also care about other things that other than survival. But survival is affected by pain. So why don't we why people they don't get good pain relief? And I think that it's not just one single variable, but I think that there are two. One is the doctor or the physician or the clinician. Let's not just focus on the doctors only. There are other people involved in your care that from the institutions, from the hospital. The oncologist could say, I treat cancer, I don't treat pain. Don't ask me about that. Let me cure your cancer. The pain will go away. The journey might be a bit painful, but so what? I don't have the time to treat your pain. It's too complex. I can see the cancer, but I don't see the pain. I cannot treat it. It's just I don't know enough about the pain. I don't know how to treat this. I'm an oncologist. They don't pay me for that. It's too time consuming. When I do cancer pain clinics, typically on a given morning, I see between 7 and 8 cases from in 3 hours. In this same 3 hours, an oncologist can see 30 patients. So imagine assessing pain if you're seeing 30 patients during 3 hours. Oncologists and some other physicians, they have something called opiophobia. They, I'm not going to give you painkillers; they are dangerous. It's very interesting. They are dangerous, but they will give you gemcitabine. They will give you, I don't know, many chemotherapies that they are so much more dangerous. But they will not give you certain analgesics because they are dangerous. And most important, and this is part of the opiophobia, patients they become addicted, and I don't want you to become addicted, so I rather have you in pain. But also patients they are on that side of the on the side of giving troubles. I need to be strong. I need to be strong, and I need to show that I'm strong. So I need to tough up the pain. I don't want to bother my poor oncologist. He or she is so busy with my chemotherapy that eventually the pain will get better. So I don't. I want to be a good. I want to be a good patient. I don't want to be a whiner, a complainer. He's too busy treating my cancer, so I'm not going to ask about my pain. And in fact, if I have a cancer, it's normal to have pain. So this is a normal pain. But if I need help, sometimes I don't know who to ask. My oncologist doesn't seem to be too engaged in answering my questions. But what about my nurse? Or do I need to go to the ER? Do I need to get an expertise from someone else? Who treats pain? The oncologist or who else? So I'm lost in the system. I don't really know. But I'm afraid of strong medications because morphine is for people dying. I'm quoting everything that I have heard from my patients. Um, Morphine is for terminal cases. And if I take morphine or morphine derivatives, I'm gonna be drugged, and I want to be aware. I wanna be alert. I don't wanna be sleeping all day. And I have heard that people they become addicted. Words like fentanyl, oxycontin, these are dangerous words. So I don't want to take those medications. I'd rather have pain. All these are barriers that help to suffer. So let me talk about the treatment of cancer pain. Not long ago, there was actually very recently a statement by the American Society of Clinical Oncology, probably the best scientific community treating cancer. There is a statement saying that opioids are by far the best treatments to treat cancer pain. By far, they are safe and they are effective. However, they are also they need a special care. So the way that the World Health Organization suggested in 1982 that clinicians we should treat pain is by using their ladder, and the ladder says that if you have a mild pain, you can start with you don't need to start with opioids, but you can start with other analgesics, conventional analgesics, and adjuvant therapy, and that's something that we all forget about adjuvant therapy. And then if the pain is doesn't get better, or if your pain is moderate enough to justify doing something else, then you can start with the second step, which is weak opioids. Weak means that they are opioids that they are not very strong, of course. Plus whatever else you can add from the step one. And if your pain persists and justifies to treat it because it's moderate to severe, then you go for a strong opioids. I'm going to go over them briefly. So yes, this way. So the first step includes Tylenol, anti-inflammatories. I put cannabinoids here because for first time ever I thought, where are cannabis in this ladder? I think that they should be on the first step. And among the pharmacological adjuvants, there are the antidepressants, there are the anticonvulsants, and the muscle relaxants. You could say, well, why do I need antidepressants if I'm not depressed? I'm very concerned, I'm very sad, but I'm not clinically depressed, so I don't need antidepressants. Well, these are news. Antidepressants, they are wonderful medications for pain, even if you are not depressed. Anticonvulsants, I don't have epilepsy. However, anticonvulsants, they calm down the nerves, all the nerves, not just the ones that they are causing epilepsy. So if your nerves from the pancreas, they are irritated, if you take an anticonvulsant, you might feel that you have less pain. Same is true for muscle relaxants sometimes. However, muscle relaxants are not at least my preferred medication, because if muscle relaxants, they might help you when you have muscle tightness. It's true that when you have pancreas pain, sometimes your back is a bit tight. That is true. But rather than a muscle relaxant, what you need is a good stretch and a good massage. For mild to moderate pain, the weak opioids that I can list off are codeine, tramadol, and tapentadol. Unfortunately, in Canada, codeine is not really a drug of choice, and the reason is because genetically we are very mixed, and some populations, they have genetic reasons for not being able to cope with codeine properly, and it might be slightly dangerous. And tramadol and tapentadol, which are weak opioids, I wish we had access, and I'm aware that I'm speaking to attendees in the US as well, so forgive me for this, but in Canada, these medications are not covered by the public insurances sometimes, and that means that my hands are tied sometimes. So sometimes I have to go from step 1 to step 3, and the step 3 starts with 3 dangerous names. Morphine, that medication that it's given to people who are dying. Fentanyl, wow, the new drug that is killing so many North Americans now. It's not the fentanyl that we give that is killing people. Is the fentanyl, the synthetic well, fentanyl is synthetic, but it's that fentanyl tablet. So fentanyl that it's lacing other drugs that is killing people. Oxycontin, the brand name for oxycodone. I don't need to talk to you about the opioid epidemics in North America and how many people they died because of Oxycontin. However, oxycodone is a wonderful medication for pain. So, but there are many others: hydromorphone, buprenorphine, methadone. These are the drugs that we use to treat pain. So I wanted to speak briefly about Tylenol. We don't really know how Tylenol works. But we know that it works for pain, but we don't really know how. We know that it's not an opioid. We know that doesn't cause addiction, doesn't even cause tolerance. We know that it's quite safe, Better not to increase beyond 3.2, 3.5 grams a day. Careful if your liver and your kidneys are a bit weak. It's not a great analgesic, but it's quite good if you combine with other things. That's why this medication sometimes in the pharmacy comes combined with other medications like opioids. Anti-inflammatories are good. However, you need to ask yourself, is cancer inflammatory? Sometimes it is, but sometimes it's not. So if there is no inflammation, an anti-inflammatory might not be too effective. It's a good analgesic. It really relieves pain, but it's relatively dangerous. And those people who are afraid of giving you opioids, sometimes you will need to say that ibuprofen might kill more people with prescriptions than opioids. And that is true because people, they bleed to death when you are on anti-inflammatories at high doses without the proper protection and if your health is weak. I wanted to put cannabis here, and I saw that from your questions, from the registration, I saw that there was some interest in cannabis. Cannabis is we don't really know how cannabis works. The plant, I consider myself an expert in cannabis, but I still don't know how it works. I know that it works, but I don't know for who. It's kind of a lottery. Sometimes you try, it works. Sometimes you try, it doesn't work. And we still don't know enough about cannabis because inside the word cannabis, there are more than 200 compounds that they have an effect on the body. So we don't really know how it works, but certainly it works. The problem is, as I said, we don't know. We can make it work the way we want in a scientific way. It's good for moderate pain, and the most important is cannabis is very safe. If I compare the safety profile of cannabis, of medical cannabis, against the safety profile of strong opioids, I will give 1,000 times cannabis and not opioids. I'm not saying that I'm against opioids. I'm saying that I'm more in favor of cannabis than on opioids. The cannabis is good for many symptoms. In fact, there was one question about nausea. And yes, it's true. When you have nausea, not only you have more pain, but also you have a terrible life. I favor the use of, so I'll put it this way. I have an automatism. If my patient has cancer, my patient has nausea, my patient is receiving medical cannabis for that. And in particular with very low doses of THC. The problem with medical cannabis is that you have to pay for it. There's no medical insurance covering it. There are some products in the pharmacy that potentially might resemble the effect of a cannabis, and then eventually you use them. As I said, we don't have enough evidence. Therefore, it's never, and I'm very serious here, it's never my first option. And is rarely my main option. So I understand when someone is interested in natural products and wants to try medical cannabis. And then I say, you know how natural is morphine because it comes from a plant as well. So let's put some education here. So cannabis also can be tricky. Cannabis sometimes doesn't work. I have to say it. I wanted to write it. Cannabis does not cure cancer. There are some anecdotes that it merits research, but this knowledge should not be translated into a clinical practice now. So if someone wants to treat cancer, not symptoms, if someone wants to cure cancer with cannabis, I will respect that because we have to respect everybody's ideas, but I think it's a mistake. I will not treat my wife's cancer with cannabis. I will treat my wife's cancer symptoms with cannabis, of course, and I did. And we have to be careful with immunotherapy. It's true that in pancreas cancer, immunotherapy is not yet the main option. More to come, I hope. But careful with CBD, because CBD has an effect on immunotherapy and renders immunotherapy less effective. And then we talk about opioids, the friend or foe. It's a friend because it's probably one of the best analgesic we have now, hands down. It's all the scientific evidence says that cannabis is effective to treat pain. This is it. It's a fact. If prescribed judiciously, it's very effective. But the if or the when prescribed judiciously, is a big when. So it needs to be prescribed properly. And not everybody has the knowledge to prescribe it properly, unfortunately. Addiction occurs very rarely in cancer cases. When someone takes opioids and with time they need more to treat, to achieve the same effects, that's not called addiction. It's called tolerance. We all have this effect. It's a chemical. Consequence of our body. We cannot avoid it. It's normal. When someone stops the opioid and feels horrible, something that we call the withdrawal, that doesn't mean that you are addicted. It means that you have withdrawal and you became dependent. And then you will say, well, I depend on opioids and I don't want that. My answer is, if you have diabetes and you need to inject yourself with insulin, would you call yourself a junkie of insulin? No, right? Because we accept that insulin is necessary for your health and your well-being. So the same is true for opioids. But this is part of the teaching that you need to give to treat opiophobia. In the past, nobody used morphine in centuries ago. Then the pendulum went to the other side. The pendulum went to the other side, and then we started using more opioids, a bit more, bit too much, and that led to the opioid crisis. Now we are on the other side of the pendulum. We're on the opiophobia side. Now it's dangerous to give opioids. There are problems because the good ones, the ones that I would like to give to my patients, they are not covered by the public insurances. I'm talking about buprenorphine, tapentadol, and tramadol. It is known that having less pain with opioids, that doesn't necessarily mean that you have good quality of life, because opioids, they have side effects, and many patients they prefer to have pain rather than some side effects that these opioids they have. In particular, for example, the central effects. So if you cannot have good quality of life by being alert and awoken during the day because you are drugged with the opioids, I obviously need to find a better alternative. There is also worrisome knowledge about survival when you take opioids. And it is probably because opioids, they affect your immune system. And if your immune system is not healthy, it is hard to fight cancer. So that's why opioids, they have been linked with decreased survival in certain cases. So let me go back to the ladder. And you have the 3 steps, but what if the 3 steps, they don't work? What if you still have tried everything and you're not doing well? This is where you need an anesthetist or an interventionalist in your team. This is where I work. This is Virginia. She's a family doctor. She was trained in pain, and now she treats cancer pain like a champion. And in this place, she's doing an injection to a patient who has pancreatic cancer and is doing a procedure. But what do I do? What do we do for patients with pancreatic cancer? Well, number one is you can do nerve procedures. We know that the pancreas is innervated by nerves, so the pain from the pancreas, even if it's poorly represented, it still is represented in the brain. So if there is a nerve that comes and goes to the pancreas, is there a way that I can damage that nerve and render the pancreas numb? Well, yes, I can. There is a technique that it can be done. I don't really need to give you many details, but the celiac plexus or the splanchnic plexus, the splanchnic nerve neurolysis, it might give good results. There is a second technique, which is the intraspinal drug delivery, which is injecting medication straight inside the spine. Let me talk to you about these two, because this is where I need your help. This is a patient from Ontario who happened to end up in Quebec for this procedure. That was quite weird. Anyway, so this patient received a celiac plexus block, a splanchnic plexus block, which is an injection of a substance that damages the nerves that they come from the pancreas. With this injection, we typically is a one-time only injection. We hope to calm at least 50% of the pain. It allows the patient, because you have less pain, obviously, you need less medication. So that's great, because medications, unfortunately, they are not harmless and they cause side effects. So patients, they feel better because they have less pain and they need less medications who are causing side effects. And this injection has no side effects. There's no numbness, there's no weakness after that. It has complications, but not side effects. That's different. And on the dark side of these injections, needles are needles. And when you put a needle in a place, you can cause a bleeding, you can cause a nerve damage, you can cause an infection, and you can cause pain, even if it's an anesthetist doing an injection. So, of course, you need to balance the pros and cons. To do this injection, you need a space, you need the staff, and you need the skills. And unfortunately, not every hospital has these services. I work in Montreal, and I serve a community of other hospitals that they don't have these resources. And I'm talking about large hospitals, but they don't have these resources. So I see these patients. It requires publicity. So let me tell you a brief story. Before I moved to Canada, I was working in my home country in Spain, and this friend of mine that I met for so long, she's an oncologist, and she came to the clinic once and she says, do you do this type of procedure? She named a procedure, and I said, I start, like, I was laughing and crying inside, saying, yes, I do. And you don't know if I do it because I have not publicized my services to you. And in the meantime, your patients are suffering. So it should not be an oncologist asking me if I do this procedure. It should be me going to the oncologist, which I do all the time, to go and publicize that there are other alternatives. Unfortunately, these alternatives, they are costly. And of course, if you count the money that you spend on medication and going to the ER and being admitted for a pain crisis versus the money that it costs to use this fancy old room and these fancy x-rays and the needles, is much more going to the hospital for emergencies. But of course, managers, sometimes they don't care about the money that you're going to save in the long run. It's just the money that you spend now, right? And talking about money, this is the real deal. And it is a tragedy. And forgive me, the attendees from the US, because I know that in the USA this is an easy access if your pain is not well managed. But in Canada, it is a shame that cancer pain patients, they don't have access to this technology. And this is a technology that includes injecting medication inside the spinal cord. 1 milligram of morphine injected inside the spinal cord equals to 300 of morphine given per mouth. So you imagine the side effects that you have when you inject 1 milligram of something. It's nothing. And the studies, they show that comparing this with pills, patients, they have better pain relief and they have less toxicity. They were very close to show that patients, they live longer, but they couldn't demonstrate that statistically. Injecting medication through the spine is done through a catheter, and you implant that device that it's a reservoir and it has a mechanical pump inside. It's like a hockey puck, a bit larger than that. You put it typically on the abdomen, and every 1 to 3 months you come to the clinic and you refill this pump, and the pump gives you extra low doses of medication, but they are very effective because this medication is injected inside the spine. And there is another thing that you can do with this pump is self-management. You have a small device that you can put on top of the skin where the pump is, and you can tell the pump, I'm in pain, I need an extra dose, and the medication and the pump gives you this extra dose. In Canadian dollars, this is around $15,000. Think about how much it costs every single immunotherapy. And oncologists, they don't have a problem in giving immunotherapy, but I don't have access to this. This is a shame. So you need a device, you need surgery, which is costly. In economical studies done in the USA, they have proved that beyond 3 months, the cost of this device is cost effective. So what we hope to do in Canada, and when I speak to my fellows pain specialists in Canada, we all cry in shame that our country does not allow us to have access to this at earlier stages, because when you are terminal, this is too late. You're not going to spend the money and ask the patient to go through this. So this is my presentation, actually, and this is me begging. I beg you, please, to fight for your right to achieve satisfactory pain relief. It is your right. You must find a way to achieve better pain relief, because pain relief means quality of life. You need to understand that opioids are necessary evils. However, you have the right to have access to other non-opioid therapies. And when I say other analgesic options, I don't just say medication. You need to be smart enough to understand that the pain is in your mind and in your brain. Therefore, you need to have access to physiotherapy, psychotherapy, nursing therapy, along with medications that we physicians can give you. And I'm hoping that your association will help us understand better pain, but mostly to get to early and satisfactory pain management. And this is me and my passion for my two girls. My third girl is the one that sleeps with me. And these two girls, they are the joy of my life. I ask you, please, to stay strong, to fight for your rights, to keep fighting for your quality of life. And this is my email. If I can be of any help, I'll be there for you guys. Thank you so much.
Thank you so much, Dr. Perez. That was fantastic, really informative. We just want to open the floor now. Does anybody have any questions for Dr. Perez?
Tiredness is a result of three factors. Number one, the disease itself. When cancer is present, it causes fatigue. It sucks your energy. So tiredness is a result of the disease, independently sometimes of the stage and the aggressiveness. Tiredness can be a result of the treatment for the cancer. So if you're on chemotherapy, tiredness is almost unavoidable. And number three is pain and pain medication. When you are in pain, tiredness, it comes along with pain, because pain drags your energy, sucks your energy. But also, certain pain medications, mostly opioids, can cause tiredness. So, unfortunately, the way that you should treat tiredness is by fighting tiredness with exercise. And this is counterproductive, because when you are tired, you don't want to move. You want to lay down. So this is probably the worst that you can do, because if you take a rest, this is not going to be restful. This is not going to be restorative, but it's going to weaken your body. You fight tiredness by creating muscle, because you need muscle, you need proteins, you need to eat well, mostly proteins. You need to be able to exercise those proteins, even if it's something ridiculous like walking inside your place. Please forgive me. I don't know, because I'm not an oncologist or GI doctor. I don't know. Typically, the Creon is to allow you to replace the function of the pancreas, because the pancreas has enzymes that allows you to digest some foods, in particular the fats. If you don't have a pancreas, or your pancreas is not functional, you need to replace that. The same way that some people, they need to inject insulin because the pancreas is not working. So if your pancreas is not functional or absent, you need Creon. But I don't know the specifics. You need to go to the Ottawa hospital and fight for your rights to have an access to a pain physician. Because the departments of palliative care, and please, this is something that I should have mentioned, palliative care is not for the dying people. Palliative care, they changed the name to understand that everybody needs support. So now all the departments of palliative care, they call themselves Department of Supportive and Palliative Care. You need support to be able to treat your cancer. But the departments of supportive and palliative care, they don't have access to these devices. I am part of the department of supportive and palliative care, but in my capacity as an anesthetist. So you need to find a way to be treated by a pain specialist. And in Ottawa, I know that there is a pain clinic. This sounds like a side effect of the chemotherapy, unfortunately. The medication that I will suggest is it doesn't make any sense, but it's an antidepressant. The medication that I will use in this case, and please forgive me if I'm giving you clinical advice not knowing your husband, but the medication is called duloxetine. The brand name is called Cymbalta. It's very good for depression, but Cymbalta, it's an actual analgesic. It helps pain, and it is also indicated in other pain syndromes, not just in cancer, but in other chronic non-malignant pains. I will strongly advise you to ask your physician about duloxetine. Also, let's not forget about the many things that you can do with your hands when the knee hurts. So cold pads, hot pads. Have you ever heard about a device called TENS? TENS is an electrical device. We have to understand that treating cancer pain is not just about taking pills. It's about being creative. There's no research about what we can do, but we need to be very creative. Thank you so much for this question. I am ashamed that I should have mentioned it before spontaneously. Someone with a cancer in the abdomen has all the numbers to be constipated. And you will become constipated for three reasons. Because you have something inside, maybe not you because you had a weak pill, but still, this is a message I want to give you. When there is a disease in the abdomen, you have constipation. When there is pain in the abdomen, you have constipation. And when you take medication for the pain, you will become constipated. So constipation is not dangerous. It's not going to kill you, but it's going to make your life very miserable. That's why every single patient that I see with an abdominal or pelvic cancer needs to have laxatives, but laxatives regular. And what I tell them is, if you have to choose between constipation and diarrhea, I want you to be closer to diarrhea than constipation, because it is crucial that your bowel system goes very, very often. So luckily, you don't need a doctor to get laxatives because you can go to the pharmacy. The types of laxatives that I recommend, because not all laxatives, they work. You need an stimulant. There is one laxative, the brand name is called Laxaday, Pegalax, Emolax. It's a powder, and this is a very good medication for, even if you take a tiny amount, it's a powder that does not taste. You can mix it with your, in theory it doesn't, it tastes a bit funny, but not too funny. There's people mixing it with the macaroni sauce, actually. It's a bit weird, though. But this is a medication that I will suggest taking regularly, every single day. If you find that it's been day and a half, 2 days tops, without going to the loo, you need to take another stimulant. The ones that I will suggest are called Senna or Senosides, or the other one that I would suggest is called Bisacodil. and the brand name of Bisacodil, the one that I know well in Canada, is called Dulcolax. I guess that, but the ones that I will not suggest are the fiber, the bulky ones, because the problem is the motor, the engine. Is not the amount of feces that you have inside. You always have to remember to hydrate yourself extremely well. I'm sorry, but 2 liters a day of water, and that will be it, actually. I hope it helps. So yeah, low dose naltrexone is very interesting. It's never the first option. It should never be alone. However, it is very interesting because low dose naltrexone is being useful in other types of pain, in particular neuropathic pains, pains from nerve invasion. I have zero experience with low dose naltrexone for visceral pain or pancreatic pain. There is one caveat: if you are using naltrexone, whenever they give you another medication for pain that from the family of opioids, that might be less effective. So it's tricky, that, because when you are on low dose naltrexone, the other strong pain medications might be less effective. So and it's quite confusing. So I really don't advise you to use that, only if it's one of the few last resorts that you have tried.
But just want to say thank you again so much, Dr. Perez. This has been a really wonderful presentation. I think it's been really informative. Definitely, I want to join in on the fight to help you get pain management to patients everywhere, because I think that's really, really important. And I think you really shed some light on opioids and how, they can be effectively used, because there is that big scarcity around it. And I think it's really cool, the options that people have. So that's great. Hopefully we can get some more funding for that. So thank you so much again, Dr. Perez, for your time today. That was great. We really appreciate it. And thank you everyone so much for attending. If anyone has any follow-up questions or anything, please feel free to email me. My email is erin@craigscause.ca. You can email me anytime if you have any questions or anything like that. Yeah, any last comments, Dr. Perez, or anything?
Thank you for this invitation. I'm next to you guys as a clinician, as a partner. Keep fighting. You are part of the treatment and you are part of the solution, or at least you are part of the journey. So don't let everybody treat you as a witness. You are part, and you keep there. You stay there. And thank you all for being there.